Hello everyone. I hope everything is going well. My name is Zahra Gambari, and today we are going to discuss a critical topic for perfusionists: how to differentiate anaphylactic shock from bleeding during cardiopulmonary bypass. This is based on clinical evidence and Mayo Clinic recommendations, and I'll guide you step by step for real OR scenarios. This is a quick comparison between anaphylactic shock and bleeding. Drop in blood pressure in anaphylactic shock is sudden and mainly due to low SVR, but in bleeding due to low venous return and low circuit volume. Reservoir level in anaphylactic shock usually normal, but in bleeding decreases quickly if bleeding is severe. When you increase RPM and if there is anaphylactic shock, by increasing RPM, blood pressure does not improve. But conversely, in bleeding, when you increase RPM, may improve blood pressure if flow increased. Triggers in anaphylactic shock is drugs such as protamine, antibiotics, and blood products. But in bleeding is surgical injury and cannula displacement. Other signs in anaphylactic shock is, for example, in skin is flushed and urticaria, and in airway you can see bronchospasm. But in bleeding, a surgical field is wet and bloody and no specific skin sign. Here is a practical step-by-step approach in OR. First, we must check the arterial line for proper setup, zero transducer at heart level, and no damping. And if it's normal, next step is check reservoir and venous return, observe reservoir level, and assess suction line cardiotomy and venous lines. And after that, we check pump flow and RPM, ensure that RPM is adequate or no. If flow is sufficient but blood pressure remain low, suspect low SVR and anaphylaxis, and if flow is low and reservoir drops, suspect bleeding. And next step is review recent events. For example, drug administration, such protamine, antibiotics, and blood products, and surgical manipulation and cannula change. And the last step is recognize signs. For example, in anaphylaxis, blood pressure drop plus normal reservoir plus skin and airway signs and plus drug triggers. But in bleeding, blood pressure drop plus reservoir falling and plus wet field and venous return low. If you suspected anaphylaxis, notify anesthesiologist and surgical team immediately and prepare epinephrine and vasopressor, support airway and circulation. And if you suspected bleeding, support volume, transfusion, crystalloid, and check cannula position and surgical field, and adjust pump flow if needed. Because I said that in bleeding, you can increase blood pressure by increase RPM actually. So to summarize, differentiating anaphylactic shock from bleeding is critical during cardiopulmonary bypass. Always start with arterial line, reservoir, and pump flow checks. Use triggers, sign, and response to interventions to guide your decisions. Early recognition saves lives and improves patients' outcome. So I hope this guide helps you in the OR, and if you are interested, please like this video and subscribe the channel. Thank you.